Welcome to another live recording of the Nursing Home Podcast, the podcast that you've learned to come and trust to give you the real scoop of what's going on in nursing homes and senior care throughout the country. Today's episode, as with more recent previous episodes, we're going to continue the conversation about staffing and recruitment. And joining me here is Eric Alvarez, I hope I'm pronouncing your name right, CEO and founder of Grapefruit Health. Eric, welcome to the podcast.
Yeah, thank you so much for having me.
Pleasure having you on the show. Before we jump into deeply, if you don't mind just sharing a little bit about your background and how you came to, I guess, create Grapefruit Health, then we'll jump into the meat. After we have the fruit for our entree, we'll jump into the meat of the conversation.
Yeah, happy. I'll go into the why we named it Grapefruit Health too, if that's interesting. But yeah, Eric Alvarez from Chicago. Pleasure to meet everyone. A Latinx military veteran founder. After the military, I got my master's degree from Rush. It's a top 5 MHA program, and I sit on faculty there today. And I bring that up to say that I work with students all the time, both clinical and non-clinical, and really understanding their needs. And that'll become relevant here in a second. After that, went over to University of Chicago and Northwestern, leading large teams, both clinical and non-clinical, really learning healthcare intimately. Was part of 2 epic go-lives as well, and getting the idea of how technology is used within the healthcare space. And then had my first foray into entrepreneurship. I was the first hire and chief operating officer of a startup, and we grew that over 5 years, and we were acquired by Cerner in the year 2020. And so it was really this intersection of academia and working with students and hospital operations, and then being deeply involved in startups to learn how to create unique solutions and actually get them off the ground that led to the formation of Grapefruit Health. At Grapefruit Health, we are addressing the massive staffing shortage in healthcare today. And I'm happy to kind of go into the business part of it now, if that's okay. And so we're going to be short by 3.2 million healthcare workers by the year 2026. I personally think that number is going to be a lot larger. We've become very reactive as a healthcare ecosystem. That happens in a lot of industries when you're short-staffed. You kind of can no longer be proactive. You sort of wait for things to cross the threshold in the ED or in the inpatient side of things. And so what you see out there for current solutions are things like travel nursing, recruiters, and even employment platforms or things like gig economy platforms. And a little bit of the dirty secret, in our opinion, is that a lot of those platforms, what they do is actually drive the transition of employment. So when you drive the transition of employment, for all those that are in leadership here, we know that greatly reduces performance and output while driving up costs. And you can talk to a lot of CFOs today at healthcare organizations and senior living facilities. They'll tell you that their FTE counts are down and their labor costs are up. And so we are solving the problem in a very different, very novel, unique way. We've created the world's first and only workforce that's composed only of and completely of clinical students. And these students, when we say clinical, is anyone pursuing clinical education, from a medical assistant to a medical doctorate. We work primarily with nursing, social work, and pharmacy students. These folks, and we can talk more about how we do it, but they join our platform, and then they're primarily doing telephonic or remote work on behalf of healthcare organizations. We charge just $5 per interaction, which is obviously extremely low cost. We hope to win on scale. And then we also help our organizations, and this is, I think, what we wanted to talk about or focus on a little more today. As a value add, we want our organizations we work with to recruit our students, and we help you do that. So a little bit about me, a little bit about the business on there.
Okay, amazing. Quite a full answer to that question. You didn't answer why Grapefruit Health, though.
Oh, sure. Yeah, sorry about that. And so, the grapefruit, first of all, when you're starting a company, you got to make sure the name's available. So that was convenient. But beyond that, it's really our analogy to healthcare, right? Healthcare is kind of is really hard. And so if you're going to eat an apple, it's easy. You pick one up, you know if it's ripe or not. You wipe it on your shoulder and you take a bite. And grapefruits are anything but that. You can't see inside. You have to kind of feel and hopefully it's ripe. And then you have to take it home and cut it in half. And then you need a spoon or salt and sugar because it's sour. And so when we think about that, the nice kind of nice little pinwheel of a grapefruit, it's exactly that. And healthcare is very challenging and requires all of those steps as well. to kind of tackle it. And then lastly, just like the little segments, the 8 different segments of a grapefruit, healthcare is very segmented as well. And we're certainly not tackling every segment of it. We are tackling specifically the ones we mentioned. So that's how we came up with the name.
I'm curious if you started with grapefruit and then you worked backwards, or you started with the analogy. You don't have to answer that.
I'll be honest here, a little bit of backwards on it. We were thinking of great names and the sort of the color and it being synonymous oftentimes with active seniors and folks. And so we worked a little bit backwards on it and kind of further justified it. But we had quite a list of names we were playing with before we selected it. So backwards, but in short order.
Got it. Okay, so let's go back to the actual problems. So the staffing shortage exists. I don't fully understand that, and I have never gotten a great answer to this. To where are all these people who left during COVID? Where are they employed? And the answer is not Amazon and all those other places, because a lot of these nursing assistants and nurses, they're not interested in that. So I know there are partial answers. I'm actually curious to hear what your take is on that first, to the why, and then we can figure out, talk more solutions.
Yeah. So where did they go? That's a great question. So what they did was, if you assume and you subscribe to the fact that the count of FTEs, of clinical FTEs across the country is fixed, right? We create some retire, but we make some every year and they graduate. But in general, the number of clinicians is fixed. Then what happened was they left their higher stress jobs, and they've done a few different things. They've either taken a break altogether. Many of clinicians are female and wanted to, that the kind of stay-at-home mom or stay-at-home dad was an exciting feature, especially during COVID, while people reevaluated what they wanted to do. I don't think that's the truth for most of them. I think that was like a pause, right? Just like a lot of people took time to reevaluate what they're doing. And they were really in unwinnable situations. I mean, if you think about ED clinicians specifically, I mean, think about what they were, basically a war zone that they were in. It was completely unsustainable. So they weren't job hunting. They left like, I cannot handle even another day or a week of this work. I am leaving. I need to take a mental health break. And I think a lot of them are coming back. But with what I was mentioning early on, there are lots and lots of opportunities for these folks to make great money part-time. And so when you go down to part-time, an FTE, for those that aren't aware, is a full-time equivalent. And so you could be a full person human being, but if you only work half time, then you are a 0.5 FTE. So even though the number of human beings within healthcare, I think, is the exact same, I think that the actual output or the amount of hours and things that they're doing has been reduced. I also think that they've now gone to innovative gig economy type platforms, or remote work is very attractive to everybody, right? So they're leaving the bedside, which is the top of their license, what their credentials allow them to do. And they've gone into really much better work-life balance roles. So again, the need across the healthcare ecosystem was 3.2 million is the gap. We lost folks, but we didn't lose human beings. We lost the points, the fractions of points per FTEs, which adds up a lot, and hence the shortage. Also, I would say that we were always short. So the year 2030 was always slated to be the year, by the way, this has been true for 20 years, that our aging workforce, clinical aging workforce, was always going to max out its shortage by the year 2030. Baby boomers, physicians primarily, they were going to leave the profession and retire, and we were going to have this gap as our societal age breakdown hits its least ideal or least optimized ratios of people retiring to people entering the profession. And when people retire is when they need the most healthcare, right? They're aging as well. And so they're leaving, and then they're becoming patients themselves. So that's my 2 cents. I mean, to your point, no one's leaving being a registered nurse to be a Python programmer, right? They're exactly. They're doing other things within healthcare, typically at less than full time. And I shouldn't say typically, I should say just a lot of them are doing it at less than full time.
Right. I mean, but the truth is, even the ones that are doing it less than full time, some of them are doing less than full time in multiple places, where the sum total is not always less than they were before. But I guess there's enough of them that aren't to make a problem.
And you're right. And I just read a case study the other day, a Mercy in the Southeast. They created a really cool solution where they're allowing folks who already are full-time to pick up additional work, right? Typically younger clinicians who are looking to make additional money. And they're working, though, at a higher dollar amount. So those extra shifts are getting paid at some sort of premium. And so now your cost per FTE has gone up, but you are having some folks. So that specific healthcare system is doing better than most as far as like their staffing, but they're paying more for it. And so it's not a comprehensive solution. It maybe not be applicable to senior homes or FQHCs or other direct care delivery mechanisms that have just tighter margins that they simply can't afford that premium.
Right. I mean, you also have to balance that with what are people doing right now anyway to fill the shortage. Either they're working short, and that's obviously a very serious problem, or what most people do, they're bringing in agency staff and they're paying a premium anyway. They would much rather pay overtime or some other fee to their own staff, where at least it stays within their company, as opposed to paying a crazy rate for an outside company.
And you're right, and I hate to be like but it's almost like, you know, the rich are going to survive, like the health systems, and I've worked for some who have incredible margins. They do really well on the bottom line. They can cannibalize and they can take advantage of some of these premium programs to keep their ratios. But where are those individuals coming from? They're coming from FQHCs and other senior living places, other places that can't pay the very, very top wage of a registered nurse. As just one example, you could say MA, pharmacist, whatever it is. They could pay the top dollar, and we are a capitalistic society. There's nothing wrong with the individual taking advantage of a higher dollar amount. I just think capitalism is, I think everyone agrees. A lot of people agree with it when it's advantageous and someone's not getting hurt. But in these rural communities or these underserved populations, they're hurting far greater, in my understanding, from the staffing shortage than of the Northwesterns of the world, the NYUs of the world, you know, the very more affluent population folks. And so you're going to see that, right? And so then how do we solve for that now? You know, that's a big problem. Right. And are people going to go back, you know, once they've had that increase? And so I don't know.
Right. I mean, and rural areas suffer in general is because no matter what you're paying, no matter what program you have, if people don't exist, the mayor is already the administrator, and the traffic chief is the director of nurses, and everybody else in the community is either a resident or a caregiver, and now you're still short. So then you're stuck. The only people left to bring in are the criminals, and you don't want to keep bringing them in. Right. But moving on to Grapefruit Health specifically, so you're taking student clinicians. Can you break that down for me? Let's talk specifically. Let's talk LPNs, because LPNs, RNs, they're hard to fill shifts. Most facilities can get a few of their own, and then they're supplementing with agency staff. What does this mean that you're bringing in the students, and where are they coming from?
Yeah, and so just to like why clinical students, I think, is really important before I even answer that. And the reason why is, if you wanted to solve what we're doing, because the work we're doing does not require clinical licensure, right? In general, this could be any individual that we train to perform this work. However, the gig economy is so competitive today. So you could drive Uber, and I think the last statistic in some geographical regions, you can make $60,000 a year working a full-time gig with Uber around your schedule, sort of thing. And obviously you're working at like the hot times in order to make that compensation. And at that dollar amount, it's really hard to compete in healthcare, especially at the wages of an LPN or an MA, CNA, things that say, that level of licensure. And so the reason why we don't go after the gig economy and we specifically use clinical students is, one, they want to get clinical experience, but they can't work 9 to 5s typically. I mean, I understand some LPN programs and CNAs, those people already are working full time, but in a lot of these professions that they can't, or educational programs, they can't work full time. And so we allow them to do this work completely around their schedule. So they earn and learn around to do that. Also, I think, and I hope a lot of people agree, the clinical student is an awesome worker. They are motivated because they want to learn. They are already semi-clinical. They've certainly taken anatomy. They might even have some clinical rotations under their belt. If they're going for an RN or even an ASN, they might be CNAs already. So they have all of this great experience, and nobody's trying to operationalize them, at least nationally, to add value to the healthcare ecosystem while they're in school. So that's some of our creativity, if you will. We're not taking from the gig economy. There's 2 open jobs for every unemployed person in the country today. That might change. We saw a lot of layoffs coming, but today that's the reality. That is the statistic. And so we're not trying to compete for top dollar against Uber, Instacart, fill in the blank. we are going after the clinical student because we think there are some massive advantages, not to mention we want to help you recruit them at the end. So that's why we use the clinical student. Sorry, I wanted to get that out there before answering your question.
I got that. So I mean, we've discussed with others, even on this podcast, where the concept of really connecting with local CNA training programs and nurse training programs, and to get them to do rotations in your facility, and many companies do this on like a one-off basis, and it's a matter of the administrator or director of nurses, driving down and making a relationship with that person. And convincing them, first of all, they have to have a certain level of their star rating, and their health inspection can't make it that they, if they have a bad survey, then many times they can't run such a program. But what you're saying is, it seems like you're saying something else. In other words, let's make it very practical. Let's take someone who's an administrator or an operator who's listening to this conversation right now, and they're saying, okay, this sounds very nice, high level. Right now, I have this shortage. What is my next step?
Yeah, great question. So unlike the example you provided about the in-person sort of student coming into the facility and performing work on behalf of the organization in person with a preceptor, which again, when you do that, and we've all mentored students, I'm sure, there's this J curve, right? You actually become less product while you're training someone. And then at the end of that training session, obviously, 1 + 1 = 2 maybe, but in the beginning, it's 1 + 1 = like 1.2, 1.3, because you're spending a lot of time training that person and onboarding them. What we do is different. We want to take your low acuity, high volume, repetitive telephonic tasks. So think about medication adherence. Think about folks that might not be spending every day with you in the home, but we are doing senior isolation and loneliness calls where we are socializing with them, capturing data with them, and doing that outreach. We're doing post-discharge follow-up calls. So whether you've been admitted to the ED, inpatient, or maybe you've been discharged even from a SNF, for example, we are doing that kind of follow-up high volume calls for you that does not require licensure. It's still clinical in nature. To do that, we have clinical oversight within our organization. So that's what we're doing. So it's very different than bringing a student physically into your organization where you're training them to do physical work. We are looking to replace your high volume human to human engagement activities, if you will.
Interesting. Okay, so I completely did not understand at all what your company does, and now it's kind of starting to come together. So basically, and it's all done remotely.
Yes, all done remotely. We built our own technology product. The student logs in around their schedule, clicks generate an interaction. We match them based on language, culture, proximity to that patient, also based on what they've been trained on, what the patient needs. It's very curated. There's a lot of quality components to this. And then they perform that work. It's a very scripted experience. We document all the information. The clients work with us to build the sort of the script and the data that they want to collect. And what they're doing during that time. So as an example, one of our first clients, the largest safety net hospital organization here in Chicago, we're doing all their diabetes prevention program enrollment for them.
Interesting. So anything that's repeatable, that doesn't need to be done in person, that is somewhat clinical in nature. So basically the healthcare provider has to create this program, I guess, in order for it to be implemented through Grapefruit Health. And then once they set everything up appropriately, so is it, do they have to pay to set up such an account? Do they get charged a fee per interaction? How does that work?
Yeah, it's a great question. So typically they're not creating a net new program. It's a program that's failing today, and they're looking to supplement it or even outsource it to us. So, for example, in the example I gave, this organization has been trying to hire MAs and community healthcare workers to do this work, and they cannot find them. They heard about our solution. It's far less than they're paying today, and we have the scale to do it. And they've also had recruitment issues. So they say, look, here's the patients with high A1C scores who we would love to connect with and get them enrolled into this diabetes prevention program. Please interact with them. And then we obviously build the scripts and the messaging with the client to do that. We then don't charge if the patient doesn't answer voicemail, bad number, drop call, any what we call not successful interactions. We do not charge for those. For any patient we actually connect with and have a conversation with, we charge just $5 per interaction. We do a rev share with the student. The students work for us as contractors. They are we own the entire HR process from training to background checks to HIPAA training, components there. We can take things like flat files from the client if it's like just a list of patients to contact. If it's something more like a post-discharge follow-up, we can do EMR integrations or other software integrations that come directly into our product.
Okay, so I'm thinking nursing homes specifically. Do you have nursing home clients right now?
We don't, but the majority of our patients we call on are our senior patients.
And so the clients are mostly hospitals, providers?
Today they are, we have an exciting pipeline, but today there's 3 healthcare systems essentially that are our clients. We're doing diabetes prevention program enrollment, health risk assessments for the largest county-based healthcare system, and medication adherence for a health system in Eastern Tennessee.
So basically, medication adherence, you basically reminded them to take their medications so that they don't end up back in the hospital.
Yeah, exactly. So we get a list of data. They specifically get it from the payer. The payer says, here's your non-compliant patients. We call them to understand why they are not taking the drugs. We're documenting that. And to the extent about 10% of those calls need a pharmacist interaction. So we're able to then do a warm transfer to a pharmacist. But the idea is that they're very short-staffed with their pharmacy staff. So instead of their pharm techs and pharmacists making these calls, we can do it for them at better scale for a lower dollar amount. And then they're all get to operate at the top of their license. So when we do that warm transfer, it's because it's a real clinical issue that only a pharmacist can handle.
Mm-hmm, mm-hmm. Where are these students are all U.S. based?
Yes, it's a requirement of ours. You have to be active student. You have to be U.S. Based. You have to have a GPA of 3.0 or higher. And then to the extent we're doing something more clinical, we require that you've done at least one clinical rotation as well.
Okay. Now, you mentioned before that one of the things in the system is proximity. Why does proximity matter if it's a remote position?
We just love the idea of students from the same neighborhood as the patient calling and having that interaction, right? It's the fastest way to build trust. It's immediately discussed. If you listen to our recordings, the students and the patient typically talk about the neighborhood even, and culturally they're being matched too. So there's a lot of data out there. I mean, I think that's intuitive, but there's also a lot of supporting data that says when you match on a lot of those things, the dialogue is much better. The trust happens much, much sooner. And then the other massive reason why proximity is important is because the chances of you recruiting our students is higher, right? So we don't want to use Chicago students. Yeah, you get it. Yeah.
No, so that's what I was trying to figure out. So I'm trying to translate this into nursing home thinking. So if I'm going to, typically there's a case manager, sometimes it's the MDS coordinator, someone who's involved in clinical reimbursement documentation, who's sometimes has the task of making post-discharge phone calls. It's a complete mismatch between talent, skill, the amount that they're getting paid with the task that they're doing, but it impacts their process, immensely, because they want to make sure that the discharges remain discharged safely, that they don't end up back in the hospital, and that there are no penalties, and people stay safe and healthy. So they do it, and also typically there's nobody in the building who is skilled enough and has the time to do it, and every other department is also short-staffed. So what I'm looking for is where's the relief, for the building, because I run a recruitment company. We're recruiting nurses, we're recruiting CNAs, we're recruiting for all these positions. So obviously get them a full-time employee that's going to sit and work for them 40 hours a week. That's, the biggest direct relief that you could do. But thinking beyond the current urgent situation and thinking about, a real solution for down the road by engaging, there are companies that I know of that the reason why I asked where they're based, that they're based not in the US, and they do a lot of these tasks for an hourly rate, and they'll go and make 1 million calls. Now, they're missing a lot of the things that you said. They're missing the trust is not there, the connection is not there. Sometimes it's not as relevant for some of the, depending on the task. It's not as important for some of the other tasks, and sometimes it is, and it doesn't work out as well. So let's say for CNAs specifically, or for nurses specifically. So we work through Grapefruit. We have, let's say, an LPN that's in school or training or not interested or ready to take a job, and they live in Chicago. They're calling or doing whatever remote task they're doing for a Chicago-based healthcare facility. Where does the opportunity for recruitment come? At what point? Is this just like a natural thing that if they like each other, they'll reach out to the facility, or is there a process for it?
There's a process. So we have the eyes and the ears of the students. We allow our clients to their HR groups to host webinars for our students that are actually pretty well attended. It could be things like, what is it like to work at this client site? It could be something just more generic, but it's like, strengthens the brand of the institution there to do that. And then as postings are available, we have our student email list, which is large now. So we make those postings available to the students in that way. But, we're learning too. So we want to find other ways to make this a little more direct in filling those gaps. And again, we don't charge for any of that. We charge for the interactions, but that recruitment part of it is just a value add, something that we hope people take advantage of.
Right. So I'm going to give you my 2 cents. Coming from the nursing home world, I think that the hospital system might be different, but from the nursing home world, they're focused right now on being able to provide the care that they need to provide, and getting the providers to do that. And they're also looking at the long-term fix of not just today, of being able to do that tomorrow as well. So the relief of the post-discharge phone calls or a loneliness call and all those other things are, and maybe some of it they're just not going to do, and it is what it is, and they're not absolutely essential tasks, some of them, and they just won't do it. And this is nice, but it's not exciting. Maybe the case manager or the MDS coordinator might be happy with that piece if someone's making those phone calls. But I think the biggest piece is if they'll be more than happy to pay for, interactions and all that, if it's someone local that's interacting with their facility with a direct line of communication to for recruitment. So in other words, you're going to work in our facility, you're a CNA and you're training, and through the platform, you're connected with us. So instead of, we had Dreambound on the podcast, and I'm going to drop their name. I don't know if you're familiar with them or not.
No.
You're not?
I'm not.
Okay.
I'm not familiar with them, no.
Okay, fine. So we had another episode with them, and they have a platform that connects CNA training schools specifically for nurses' aides to nursing homes. And so this way, instead of you going one-on-one with your donuts from place to place and trying to create relationships, they want relationships with nursing homes. Nursing homes want relationships with the training programs. They're connecting them so that it's a win-win. The training program has a place to do their clinical rounds, and then at the end of that, it's very likely that they'll get hired. And that's like directly addressing that staffing shortage head on. And for the facilities to have the capacity and are certified to be able to do that, then that could be a win-win both ways. This is doing it in a less aggressive way. In other words, the immediate payoff, I think, is not as substantial, not as exciting specifically for a nursing home operator, because the pain point is who's going to answer the call bell in room 201A right now. The person wasn't, toileted in 3 hours, and it's horrible. Someone has to deal with that. So this is not an immediate fix to that, but this is developing the relationships directly with the talent pool, who tomorrow is going to be looking for jobs, or maybe even today already looking for jobs, and getting to them another way. So just to be straight out, the recruitment piece is what they're going to figure out. What do I need to do to be able to make you send my job to a targeted list of people whom are interested? And not only that, they through the program, the way you're describing it, it sounds like the relationship is there. They're not just scrolling through Indeed and looking through job posts. They're actually, I know that facility. ABC Nursing Home down the block. First of all, I drive by every day. I make phone calls for them, and I know that Sally and Joe were discharged last week, and I know about the meds, and they called into whoever it is. They called someone in the pharmacy and that person just took care of the meds, and now they didn't have to come back into the hospital, but they went back, whatever, so then they're already kind of involved without being involved.
No, I love that. Thank you. Yeah, and honestly, this has been educational for me as well, on there. And so, yeah, I think you hit it right on the head. I think you're right. I think the direct value is delayed. I think it's really about creating these internship opportunities. They understand the brand. They understand the patient population, and so for them, it's a natural progression to take a position with them post that work and as they near graduation. So.
Right. It's also a very low risk way of entry. In other words, I don't have to get into my car, drive down to another interview when I already confirmed 7 other interviews, of which I never planned on showing up to maybe any of them. Which is how it works. I can tell you firsthand experience happens every single day in all positions, by the way. It happens to administrators and directors of nursing and regional positions that people just don't show up. But up here, it's very different. My commitment is very little. I'm gonna when that ping comes in, or however exactly the system works. But when I get that call and it's a local facility and I'm interested and I pick it up, and I start doing this, whether it's on my phone, I assume, or some video call or a phone call or whatever it is, I'm beginning to develop a relationship with the local senior population, as well as with the providers there. And I see that is, even if there wouldn't be a direct recruitment built into the process, but if they're then looking for a job and they see this facility, oh, I know that place. Just like my grandmother used to be there, and my friend works there, so now it's like, oh yeah, I Ubered there, right? Through the system, I drop off the eggs there on Tuesdays, so now I make their discharge phone calls. So it kind of creates that connection without the risk or investment that they would have to make of, okay, this is a serious job interview. Am I going to do this? Am I going to do this? You know what? Forget it. I'm not showing up. But here's like, I did a little thing on my phone or whatever, however it's done. I think that's a much lower risk and a easier, takes away some of the barriers of entry. If I can ask, the bulk of the calls, I'm trying to figure this out because you mentioned the isolation and loneliness. You mentioned the post-discharge follow-ups. Are those the 2 areas where most of the interactions are, or other benefits that healthcare providers are getting from the system other than those 2? Not that it's a problem either way.
Yeah, it's the bulk is really program enrollment specifically around diabetes, health risk assessments, and medication adherence. To be totally transparent, we haven't done. We've scoped it out. We for all intents and purposes, it's just a matter of turning it on. But we have not done post-discharge follow-up as like an example. So our menu, it's sort of like, if you think about the work, the menu can be quite long, right? Like, what are the opportunities? Like, we have, some clients that are interested in like high-risk patient check-ins, right? Which we haven't done, but it's really, they script the dialogue. We have it. We capture data utilizing a human-to-human interaction with some text messaging.
Got it. What about more in-depth work that is not interaction-based, such as chart audits and things that can be done completely remotely once you have access to their EHR, but it's not the human-to-human connection. It's not just maybe the human-to connection, which I know people are outsourcing right now. I'm curious if that's something that fits the model or not.
It's a little outside the model in that I'm not saying it wouldn't be educational, but we are really focused on the impact side of this business too. And we want the students to become better clinicians through the work with us. And so I think like a chart audit, a few of those would be educational. I think after several hundred, that becomes maybe less educational. So the idea is, like, today in a lot of clinical programs, they get almost zero telehealth or telephonic training outside of simulation. And so what we want to do is actually prepare them for that, because that is where the future of a lot of these roles is going, or it's a big component. When I managed, for example, a lot of nurses in the health system, they spent a lot of time on the phones. And the first time they did that was their first day on the job. So they're not getting trained on how to do that. And so as long as the work is educational for the student, that is one of our criteria before we would take on a project.
Okay. I mean, I can make the argument that chart audits is extremely educational for them to see how all the different pieces of the medical record tie together and how you read a story. Just as a finance person will tell you that, financials of any business is going to show you the story of what's going on. The same thing is true clinically, but maybe up to a point.
Yeah, I think
You
that's and like we've had clients approach us for like prior authorizations, and I think prior authorizations are actually educational as well. It's just not, it's less direct to the patient. It's more about understanding how the payer system works and why certain parts of document, things are required for the revenue cycle. And I agree. I think it is educational. It's just a fine line. And so we just have to be careful that programs we take on are educational, and that the students, we do think that we're preparing better clinicians than, something different than that.
Mm-hmm, mm-hmm. Fascinating. Very, very interesting. Very, very fascinating. This is not all what I thought that the company does. It's definitely the first thing is just zooming out of this conversation for a minute. And I know that we're a little bit over time, but we'll wrap up in a moment. But it's a unique approach to dealing with with some of the staffing shortages. We're not head on saying bring people in from other countries, which is a solution that does work for a lot of people, or convince people why they should work in house versus the gig economy. Not fighting the trend. It's kind of providing value to the trainees who, whatever stage that they're up to, that this is something that they need, or should know that they need. It definitely supplements their current education, whatever it is, and at the same time offers that opportunity of beginning that relationship with the facility. I think a big challenge, and I'm telling this from firsthand experience, because our company, Quality Recruit, this is what we do, and we reach out to this exact same people. But a lot of times the problem is there's a cold connection. There's almost like a wall that's up. Like you're just another guy just trying to give us, another job, and every nursing home is the same, and they have no idea who our clients are. Some of our clients, they're not the same. They're fantastic, clinicians and healthcare providers. It'd be a little bit better if some of these people would accept the jobs and work.
Yeah.
It's a vicious cycle,
Yeah.
but at the same time, so this kind of softens that barrier in general, so that they can come in. So even if someone doesn't need any help, I'm just thinking this through right now. Um, it might even be worth to creatively come up with specific, training opportunities, so that and the price point obviously is negligible. So even if it means I don't know if these people do hundreds or dozens or whatever the number is a month, but just being this value of being able to interact professionally with the local talent pool that you're desperate to hire, it's that really makes a lot of sense. I guess my question is, where is it available? Is it
Yeah,
available
we're
on patients? How does that work?
Yeah, and so we are national. So we have the clients are sort of the clients that we're working with today is somewhat spread out. And so the way that we work is essentially is once we're enter contracting with a client, we have a mechanism for developing this workforce very, very rapidly. So in less than 6 weeks from recruitment of the students to fully trained, ready to go is how long it takes us, which is about, depending on the size of the organization, contracting can actually take a lot longer. And so you can imagine, doing a sale with a large healthcare system, there's security reviews and MSAs and SOWs, BAAs. And so once we're far enough along, we can sort of time it now. We've gotten good at timing it, that the go live, the students in the workforce is trained to perform that task. And so, for example, one of our first clients, from handshake to go live, introduction to go live, was 4 months. And we do on that recruitment piece too, which was interesting, just as an aside, we do have 2 clients that have come to us purely on the recruitment side. And now they're, because of the cost you mentioned is so low, is that they're now looking to spend those dollars on interactions, and they're searching for folks, clinical teams in their organization who would benefit from those interactions. And so they are that not in the term desperate, I don't mean in a negative way, but like they're so interested, I should say, in novel ways to build the workforce, because what they've tried to do today just hasn't been effective. And
Right.
so,
In other words, right. So this is kind of what we were saying before, is that if
right,
I'm going to give $1,000 to Indeed, or $1,000 to someone else, or $10,000, wouldn't it make sense to allocate some of those funds to get, first of all, you're getting some actual work directly back,
right.
and to creatively find opportunities for them to interact with the facility. But as not like CNA training where they're physically coming into the building, where obviously then that's a much greater exposure, but it's also much more difficult, to do that. And for that, we have solutions like Dreambound and others, for that to work. But specifically here, where let's find a way to, for some sort of task that can be outsourced in this type of, price per interaction model, so that we're starting to connect with local people. If it wouldn't be that, that's why I mentioned before the proximity piece, because if that wasn't there, then I could tell you from a nursing home standpoint, it's like, okay, it's a kind of cheap way of getting, some of the stuff, some of these tasks, and it may not always be such a low price point. If you have lots and lots of calls to make, the money may add up. If you're looking at it from a recruitment standpoint, where there's a massive budget to begin with because of how urgent the problem is,
Yeah.
so then that's a whole different way. We're not looking at Grapefruit versus hiring someone in the Philippines or El Salvador or whatever. We're looking at Grapefruit versus Indeed, Grapefruit versus Glassdoor, or versus a job fair. And obviously the budgets are very, very different, and you also get that added benefit. This has been absolutely amazing. Very, very interesting. We definitely need to wrap up. Anything final that you would want to share with our listeners and viewers before we wrap this up about Grapefruit, before we let you go?
Nothing specifically, just really thank you so much for your time and attention. You could find me just eric@grapefruit.health is my email, or LinkedIn. Would love to connect really with anybody. But yeah, no, thanks for this. It's been fun for me and educational at the same time. So thanks.
Amazing. Thank you so much for